It's a pleasure to be here with you. Thank you for inviting me. So my name is Elisa Konofagou. I've been at Columbia University for almost 20 years now, working in the area of therapeutic ultrasound. And as I'm going to show you today, over the past almost 80 years, we've been working on modulation.
That's super. So yeah, let's get started.
There's a lot of excitement about ultrasound being applied to the brain. Of course, we're not the first people to want to do modulation in the brain. There's a lot in the clinic, such as DBS, deep brain stimulation, that's used for the treatment of essential tremors. And more recently, of course, optogenetics has been shown through some genetic modification to also be able to stimulate and look at neural networks. And of course, also in the clinic, we have non-invasive techniques, unlike DBS and optogenetics, such as TMS, transcranial magnetic stimulation, that uses the magnetic coil, a wire, and induces electrical fields into the brain as a form of modulation. Of course, you can do this also electrically. So the clinical applications are several, and from what the Brain Initiative is hoped to do, which is basically non-invasive mapping of the healthy brain, it's very difficult to put in electrodes or even do genetic modifications in healthy humans. And of course, on the other side, for treatment of diseases, such as I'm going to talk a little bit about pain today, Parkinson's, of course, that is embracing as a field much more than other fields, the devices for modulation, and other more recent applications of this. And of course, for diagnosis as well, depression, autism, bipolar have been some of the disorders that have been proposed, and with some applications for diagnosis. Addiction, and also something that we worked a little bit also on our end. I'm not going to talk about it today because there's no final results or conclusions that we can make yet, but definitely a big area of potential application. And also assisting what's been done and approved for in the brain right now, which is the treatment with ablation of essential tremors. And potentially some of the side effects of paresthesia of lips and fingers that have been reported as a result of ablation could be, through modulation, potentially avoided. So we put together this schematic a few years ago now about ultrasound. I mean, but maybe this audience doesn't need to see this, but we basically completely non-invasively trying to modulate the brain with a transducer. Either for us, for my team, is outside the MRI, but of course, your group, Kim, does it in the MR, and this is with advantages of being able to monitor constantly in the MRI. And overall, focused ultrasound has the advantages of both worlds, meaning that it is non-invasive, such as the TMS and TDCS, for example, but it also has deep penetration, such as optogenetics and DBS, as well as a good precision. So it combines the best of both worlds. And of course, we embarking on, all of us, in this journey of understanding also what we can do, how we can supplement or complement what the other techniques have been doing over the past few decades. What I'm going to cover for my talk, I'm going to start with the central nervous system and give you a little bit of a historical background of what we did in the first applications of FAST in the brain with both cortical and subcortical modulation. I'm going to shed some lights in what we try to do in my group, which is basically understanding more the mechanism and monitoring of the modulation. We have also found that other than motor and cognitive, we also have cardiorespiratory modulation. I'm going to talk about that as well. And then I'm going to shift gears to what we can do also with ultrasound and microbubbles, which is also opening the blood-brain barrier. And that has modulatory also results on the brain. So I'm going to talk about this, especially cognitive and some motor changes. And then some translation to humans that we've done in Alzheimer's. I want to share this quickly. And the final part will be on periphery. So what we know from exciting nerves, not the brain parenchyma, not neurons in the brain, but actually on the nerves, and what potential channels could be implicated here. We've done more physiology mechanism here. And also the tissue level as well. We're going to relate displacement of the nerve to modulatory results, and then some translation to humans. Okay, so we start with the rodents. We started with rodents, and as we know, ultrasound penetrates through the skull, but it doesn't penetrate through air. So we still shave the fur of the mouse, but that's the only thing we do. The scalp is intact, and then we target different parts of the brain. And one thing that I want to highlight is something that we've looked at different parameters from duty cycle, 6 to 50%. A pulse length is on the order of 1,000 cycles, but also the anesthesia that all of us have to use in rodents. But as we know, if it's light, then you enter in a different type of cognitive state of the animal. And so we opted to do deep anesthesia because of the hardships that we found over the years using very light anesthesia and being at the mercy of some auditory effects, as others also have reported. So deep anesthesia is typically what I'm going to show you first with pentobarbital, and we make sure that the heart rate drops under 400, and then we have the mouse deeply anesthetized. So this is some of the work that we did initially with the transducer on the contralateral side, and we had this lateralization of the motor response. So on the left hemisphere, we were able to get a right contralateral response, and then we shifted the transducer to the other side, to the other hemisphere in the somatosensory cortex, and we were able to elicit motor response on the contralateral limb. Now, as you can see on the bottom right corner here, the green is contralateral, blue is ipsilateral. So we don't only get contralateral, we also get ipsilateral. And we still don't understand why, but I may shed some light on that. It looks like when we go contralateral, we don't only have that hemisphere that's potentially responding. But we did get in that video contralateral responses. And I'm going to shed also some light about how the parameters could also affect what we're seeing. So speaking of parameters, first things first, pressure. I know some people have looked at also intensity. We looked at pressure, and it does actually dictate two things, whether you're going to get a response or not. That's the EMG response, the motor response I'm referring to. So similar to what I showed you in the video, we actually are following the motor response. And then, of course, the latency. So how fast you're going to have elicit a response. So you can see as you go from 1.12 in this case, megapascals to 1.79. So in the first decimal change, you already see that you can go from no response to some responses, and then the latency also shortens as you increase the pressure.
Yeah, Elisa, maybe I'm getting ahead of things here, but it seems like your pressures are really high compared to the ones that we're using, but you're also using a higher frequency. Do you think you need more pressure at higher frequency? I mean, I know we've shown that you do, but I'm just wondering what your take is on that.
That's a great question, and I don't have a definite answer for you, Kim, but we are looking into that right now, and I'm going to get to the potential. It could be also a different mechanism that we're tapping into here. There's definitely some thermal temperature increase here as a result of higher pressure, but also the higher frequency. Obviously, you have higher absorption. I know some people who use 200 kilohertz or 500 up to 500 kilohertz have used much lower pressure. So, so just to tell you that we haven't done that work.
Yeah. So the other thing that's interesting here is it looks to me, and correct me if I'm interpreting this incorrectly, is that that you do a number of sonications and then you see a response after some number of sonications, but that number of sonications is lower as you increase the pressure.
Correct. Yes.
Yeah.
That's the latency. Yes. So you see it. Yeah.
And so, well, I guess that's a latency. Yeah. So I mean, there's different ways to calculate that because you could say for any one sonication. But anyway, so my question here then is, it seems like the effect has to sort of build up. And so does that point you in the direction of temperature?
Yes.
Okay.
In
Okay.
this, okay, yes, absolutely. I'm going to show you the temperature rise later. You also have, it's not, and something that we can also talk about throughout is not one or the other. Obviously, mechanical happens throughout, whether you have temperature gradient or not, but you definitely have a temperature rise here at the same time as a mechanical displacement, what we have resulting because of the high pressure.
Okay, thank you.
Sure. Yeah, so we also looked at subcortical targets. So we had a discussion at the time with a neuroengineer in the department, Chi Wong, who painstakingly makes sure to insert electrodes into the mouse brain and reach areas such as the superior colliculus, which has sensory information, especially for eye and head movements and pupil dilation. And then the locus coeruleus, which is also a very important target for inducing arousal, anxiety, or stress, but also pupil dilation. So he was able to do this with electrodes, and then we said we will try to find that kind of stimulus with pupil dilation, for example, more sensory with ultrasound. So here's what the infrared camera showed. So ultrasound is on here. And it's very difficult to see, but we can see the diameter change of the pupil up to about 40%. And then the ultrasound is switched off, and then eventually the pupil goes back to the original diameter. So we're very happy with that. And this is a sensory, I think this was a locus coeruleus target. And this is a superior colliculus. This was a bit different. We couldn't actually see necessarily pupil dilation, but we could see now the eyeball move. And we were not sure whether we were hitting a nerve or whether we were hitting that region of looking at both the movement of the eye, but also, where it was pointing towards. So this is something that we weren't sure what the mechanism was, but we definitely saw this in a couple of animals. So then we pushed it all together. Some of the animals would get both eyeball movement and pupil dilation. And these are 3 of the mice that we had here, depending whether we were at the superior colliculus or hippocampus also elicited some of that, some of these responses, as well as the locus coeruleus that I mentioned. So,
so sometimes you can get movement of the eye when you stimulate the vestibular system. I'm just wondering.
We weren't sure exactly. This was not clear exactly what. I mean, we're targeting mainly those regions, but we could also within the vestibular vicinity. So this is something that, we were not targeting specifically there, but we got that response.
Oh, sure. It's just, the ultrasound can travel. We know that it goes to the inner ear, and the vestibular system's right there in the inner ear. So,
yeah, yes, exactly. So, and then we pushed it all together. That's work by Hermes Kamimura, and he basically showed the motor responses at 1 millimeter from the skull, and then the sensory responses mainly subcortical 3 millimeters down. So, and then, we wanted to see, obviously, like all of us, we're trying to see, what happened, why did we elicit this response, and what would happen to the brain. So we inserted a thermocouple subcranially, and then we removed, obviously, viscous heating artifacts. And they could see that 50% duty cycle was where we saw the lateralization of the response, and everything that I showed you so far was under this regime, 50% duty cycle. We could see that almost instantaneously the temperature jumps by almost 6 degrees and is maintained at that level. More recently, we've been using 6% duty cycle, and even that is on the order of 2 degrees C. So that's something that we cannot necessarily avoid, at least with that frequency that we're using. And we're still using frequencies at the megahertz and 1.5 megahertz. But we feel like this temperature is part of the mechanism here. Okay, so another more recent development is that we also apply blood flow.
Elisa,
So
could I just ask you to go back for a moment? So, one thing that you could do to kind of modulate the temperature is just to have more time in between the pulses. Did you try to do that by any chance, just to try to decrease the temperature?
yeah, so this is a 6% duty cycle. So that means that you're on for 0.3 seconds and you off for 4.7. So you're spacing it out. We could actually space it out even more and go to 1% duty cycle, for example, and get that temperature to go down more. But these are the two regimes that we had responses, and we went with those. And I just want to say that the second one, we used also isoflurane. So this is the Christian Arp's paper back in 21 used isoflurane here. And that could also, we looked at auditory effects. I'm going to report on that. But we definitely, that may also have the anesthesia effect here of being different. And that's why we went with something that happens in the brain, because obviously, the paw is as far from the brain as you can get in an animal. And you have to have the actual potential travel all the way, and and get an EMG response that you can measure. So you have to obviously amplify the effect. So we wanted to see whether we can measure inside the brain what happens. And for those who are not familiar with functional ultrasound, is a power Doppler technique that can highlight the blood vessels in the brain. So with ultrasound, this is some of the compounded images that Kristen has taken, and you can see that B modes, and I'm going to show you a couple of ultrasound images of the brain. Even after craniotomy, it's not really very easy to see structures. But as soon as you actually do functional ultrasound that has been developed by the group in Langevin in Paris, you can actually highlight a lot of the capillaries, arterioles, and even large arteries in the brain. I'm going to show you examples of that, and in order to be able to see whether you're getting a blood flow increase as a result of the ultrasound application, we do correlation analysis that we have now published. This is a paper that just came out actually in UMB. And then we do spatial temporal filtering with singular value decomposition to identify different regions. So large blood vessels for, veins and arteries here, subcortically, or we remove tissue and clutter if we have to, and also highlighting capillaries versus venules. So now I'm going to show you the video. So we're stimulating in the middle of the brain here, of the rodent brain, and then you're going to see that we're not getting stimulation only in the region where we where we were stimulated, but in both in cortical regions specifically. And if you missed the video, I'm showing you here the peak blood flow that we see. So it's at the focus, but also the correlation analysis showed that we have a lot of blood flow increase on both hemispheres, especially in the cortical region. And then when we quantified it, it looked like we did have the response at the where we actually focused, which is the blue curve, but we also had it outside in the two cortical regions. So that's something that we have actually done a few of these experiments in mice, and we get that with craniotomy and without. So we're trying to understand what is happening, but it's definitely, that could shed some light about why some of us are not necessarily getting consistent results in rodents. Another aspect that we also have found is, us and others, by the way, is that we are inducing a cardiorespiratory effect, modulation, and especially if we have inside our focus, and this is through a simulation, a K-wave simulation that allows us to see our focal spot, which is here in red, and these are the reflections of the skull. We actually see that if the hypothalamus is included, which is, as we know, a temperature regulator in the brain, If it's included in the focal spot, then we do get these effects more reproducibly. And you can see here the bars, the gray bars here are showing you when the ultrasound is on. White is when the ultrasound is off. And the heart rate here drops momentarily during ultrasound. And then overall, the rise that you see here is as the animal is coming off from anesthesia, or it's changing, its heart rate is increasing. And there has been papers, as we know, that show that ultrasound can awaken or can accelerate awakening of the animal. And then the breathing rate in this case is actually the opposite. The breathing rate increases as opposed to the heart rate, and then goes back almost to baseline, but overall also increasing as a result of the anesthesia, or potentially also the ultrasound. With I don't have the sham here to show you.
Yeah, because, you know, of course I'm going to ask, do you think that they're hearing the ultrasound plays a role here?
So that's a great question. You mean hearing and then changing the heart rate? Yeah. We actually did a different location where it didn't include the hypothalamus. I don't have it here, but it's in the paper that's going to get published hopefully this year. And we didn't find that there was overall there was an increase in the heart rate and the breathing rate, like I'm showing you here, but not as a response to ultrasound. Another thing that alludes to what you were saying, Kim, about pressure, is that we have been inspired by the other papers that they'll use a very, very low pressure and they can get modulation. So what if we use imaging, an imaging transducer? I know that we're all working on FUS, and I'm not saying TAS because obviously TAS is taken as transcranial ultrasound. So initially we had theranostic ultrasound, and now we call it thus. So it's a work in progress. But we have a transducer that basically can transcranially open the blood barriers I'm going to show you and induce modulation, but also without opening, you could potentially modulate. Some of the work that we've done is also with gene delivery that I'm going to talk about later. But with just an imaging transducer, you can potentially also modulate the rodent brain. So when it comes to cavitation, because of the resolution of the imaging transducer, unlike the focused ultrasound transducer, you're able to get the resolution that you have with, for example, an 18 megahertz array that we've done some of the work that we published a few years ago now. And that also correlates nicely. In this case, we opened the barrier here, the MRI, and we were able to see cavitation was overlapping with some of the opening regions of the MR. And more recently, we published on the fact that we can actually map the cavitation in two different regions at the same time. So we're steering the beam, and we can get cavitation on both sides of the hemispheres. And that also correlates nicely with after opening with gadolinium. And this is more work with the number of cycles. That's with 1.5 cycles, you can open the barrier. You can also potentially modulate. 5 cycles, 10 cycles increases the volume and increases the intensity of the cavitation. And that has implications in the blood-brain barrier opening volume and signal intensity that we're getting with the pulse length. So that's something that we're interested in using also in modulation, not obviously with bubbles, but potentially using this in a modulatory role. Now, another mechanism that I mentioned earlier is the displacement. So just because you're getting temperature, elevation doesn't mean you don't have displacement, and vice versa. Just because you get displacement doesn't mean you have temperature. It's much more difficult to measure displacement, we found, in the brain because of a lot of reflections. This is some of the early work that we did using an imager very similar to what I showed before, a theranostic probe. In this case, we were modulating with FUS and imaging with ultrasound at the 17.5 megahertz frequency, and we could see that we had a lot of noise, but also some displacement that was increasing as a result of focused ultrasound. More recently, we have developed a technique that uses oscillation, so amplitude modulation of that beam. And this is what after craniotomy, what the ultrasound image of the brain looks like. And we were able to see at 100 hertz, this region, we were not sure exactly which region that was. It was appearing very bright on the ultrasound image. And that had 100 hertz, much higher displacement. As we were moving the beam around, I forgot to say, we're moving the beam around and we're modulating each part of the brain. So almost like tapping to the brain across, I think 15 locations across. And we could see that this region was much higher displacement for some reason in a live animal. And then we had a frequency dependence assessment by changing the amplitude modulation frequency. And we found that at 100 hertz that I showed you in the previous example shows this region as having higher displacement, but that doesn't necessarily mean that this appears in every frequency. And in fact, at higher than 600 hertz, we were getting some other displacement measurements, which we're still trying to understand what that means. Much lower displacement than what I showed you before, potentially challenging our sensitivity here. We're using that work with what we developed, which is a surrogate of the stiffness here. So we call it the inverse slope technique. So this is a work that was performed by Murad Hossein, who's a postdoc in my group. And he was able to get the frequency dependence of the displacement and then have a linear regression fit, and that inverse slope will tell you what the stiffness will be. And we were able to find that the cortical region here was stiffer than this region here, the subcortical region. So this is very new stuff for us, and we hope that we can, share this soon. This was something presented last year at the IEEE Ultrasonics Symposium. And but we think that even the fact that we actually map the stiffness at the same time, we potentially can modulate because of the pressures that we used here. The pressures that we used here were on the order of 2 megapascals with a 12 megahertz array.
Mm-hmm. Yeah, it's really interesting because it's this whole thought that if strain is the mechanism with modulation, then we might want to know something about the stiffness of the tissue in order to back out the strain. And yeah, so it's pretty interesting.
Yeah, and some MRI elastography, I think, have shown that after you modulate the brain, it becomes softer, if I'm not mistaken. So there's something that we can also measure as a result of the modulation.
Yeah, it's pretty interesting, the work on functional MRE.
Yes.
Yeah, exactly.
Mm-hmm. So we hope that we can do something on the ultrasound side and confirm some of these results. Mm-hmm. You mentioned the auditory effect, Kim, and that's very important. We looked at that quite extensively in the big study with mice here. And we randomized between focused ultrasound and auditory stimulation, which was basically at 16 kilohertz tone that the mice were exposed to, and then sham, which means no tone, no focused ultrasound, but just ambient noise. And we found that that focused ultrasound had a 96% success rate and a shorter latency compared to auditory, that we didn't find that we could stimulate or we could see any motor responses in this case.
Yeah, I'm sorry, I missed here. What is your readout when you say success rate?
EMG.
Okay. Yes. And how loud was the sound that you were playing?
It was 93 dBs. It was pretty loud.
Yeah.
I mean.
Okay. Yeah. Mm-hmm.
Especially for rodent, you can hear it obviously.
Mm-hmm.
And the sham was actually more successful. The ambient noise was actually more successful than the auditory stimulus. I mean, but the latency was much longer. So we could get EMG responses with ambient noise.
Well, I
But
mean, there's just some rate at which they just respond spontaneously or have twitches spontaneously. So, yeah.
exactly.
Hmm.
Exactly.
In
So
fact, it's sort of surprising you don't have that with the auditory.
yes, right. I
Hmm.
was not
Hmm.
sure why this was happening, and the
Hmm.
auditory stimulus then we concluded under deep anesthesia was not eliciting a response, and the FUS had a significantly lower latency than and success rate, higher success rate than the sham and the auditory.
Okay, so this was with deep anesthesia. Can you remind me how much anesthesia did you have here?
So here it was pentobarbital, and I have to get back to you on that. It was very deep to the point where you can we were basically pinching the toe of the paw. I'm sorry, the paw of the mouse, and it was not. We're constantly testing that. I don't remember the level, but I can get back to you on that. But it was very deep. We did a lot of isoflurane in the beginning, over months on end, and we're getting so much spontaneous response that we basically backed out of isoflurane completely for a while. The isoflurane was used in the cardiorespiratory. I have to mention that. That's why we did a lot of the sham. That's in that paper. But for this auditory effect, we did the pento.
Mm-hmm. Mm-hmm.
All right. I alluded to the blood-brain barrier earlier. I don't know, for the sake of time, I think I'm going to go a little bit faster here. So normally we open the barrier to deliver drugs, but we found through safety assessment that the barrier, after it's opened, could also have some cognitive and motor responses in animals, at least, that we were interested in seeing. So the difference is when we open the blood-brain barrier, instead of just shining ultrasound to the mouse brain, we also inject microbubbles that are designed to resonate at the frequencies of ultrasound, and then we can even administer a contrast agent or a drug to see that we open. And we use MRI for that to see where we opened and which regions. In this case, we were doing some coded putamen targeting and substantia nigra that are the two ends of the dopaminergic neuron that's affected by Parkinson's disease. And we also, of course, perform T2 weighted and T2 star weighted images to make sure that it's safe. Now, this is where it became interesting, and I have to say this is very serendipitous because we were not expecting it. We just wanted to basically, in this case, treat Alzheimer's with a drug that will not penetrate normally the barrier. But then we had a lot of the behavior, such as this one, which is Morris water maze, that tests the spatial memory of the animal by using some landmarks that you train the animals in a little swimming pool here to have that has the platform. That then you have the platform under the water that's murky, they can't see the platform, but they remember that it's there, so that you know that the memory has not been compromised. So the target is here, and you want to make sure if the animal has not a compromised memory, then it will always find the right target, as opposed to swirling around the pool trying to remember what the target is. So this is a very, common neuroscience memory test. So the first thing we did with this Alzheimer's transgenic mice is we basically compared sham, so no focus ultrasound per se, but everything else, not the focus ultrasound was not on, but they were exposed to everything else. And then we see that the transgenic animals could find the 29% of the time the right platform, but when we actually opened the barrier here with focus ultrasound, so no drug, they were actually doing better. The animals that had cognitive deficits as a result of Alzheimer's. And then the even more interesting thing is that their litter mates, the ones that do not have necessarily the cognitive deficits because they don't have the genetic predisposition, we could also improve those, so that the non-transgenic shams versus the sonicated ones also had an improvement. So that was very interesting to us, that we were only looking for safety. We were trying to see whether focused ultrasound here, opening the barrier without a drug, was actually safe. And then we found that we were actually enhanced memory. And this is some of the actual metrics here: 31 to 35%, from 31 to 35% increase here, and then 38 to 43%, also for both transgenic and non-transgenic. And then we wanted to also do something similar to the monkeys. Again, safety study. This is how we open it transcranially at 500 kilohertz, and this is a gadolinium 3D rendered MRI that shows you also the skull. And again, very also serendipitous here too, and that has been reported also by others in rodents, that we could see that there's neurogenesis as a result of opening the barrier. This is with DCX staining, and you can see this in red. Some neurons that are appearing here, new neurons at acute phase, so the 2 days after we open the barrier, and then they're gone 18 days later. So that's something that we saw in the non-human primates. And not a lasting effect, but nevertheless something that could potentially be linked to what we saw in the mice. And definitely not necessarily changing with the mechanical index. So whether you were safe, so the FDA approved us to do this in humans, as I'm going to show you, at 0.4 mechanical index, which is something that you use with microbubbles in imaging. So going back to the theranostic aspects. And then at 0.8 as well. So very similar effect, whether you were using high pressure or low pressure. And then by partnering with neuroscience, a primate neuroscience team here at Columbia, headed by Vincent Ferreira, we were able to see that we have some improvement in the accuracy of this behavioral test. So this behavioral test is testing the motivation of the animal by rewarding it when it gets the right target. This is a rectangular Q target here in yellow. And when Vince also has coded some kind of a coherence cloud, where you can see that if it rotates towards the right, then you expect the Q to move to the right. So that also tests the attention of the animal. And then it gets rewarded if it's horizontal. So it knows it's going to get a higher reward. And then you test also the motor accuracy and speed as a result of motivation. So a lot of things that are tested here during sonication, by the way. So it's a very interesting awake animal setup that we mounted with Vince in his rig, as he calls it, where he has the screen in front of the animal, and the ultrasound is constantly on for thousands of trials.
Yeah, I'm a little confused by this. So did you compare to the situation where you did the BBB opening before, or is the sonication always during the task?
It's during the test, when I'm going to show you.
And if you had done it before, there would be no effect, or?
Actually, we did, like, the very first that we did was before, and then we tested the animal, because actually we will open the barrier. Yeah, we will open the barrier and anesthetize NHP, and then perform the task after the NHP is awake. And there was an effect there, but with anesthesia and coming out of the anesthesia, it wasn't clear. It wasn't as consistent across animals. And then we built the awake animal setup to make sure that we get anesthesia out of the way as an effect, and that we only see during the actual sonication.
Okay, so I'm a little confused because if you can get by without anesthesia, then why did you have to have anesthesia when you sonicated before?
It's just for historical reasons, because we only had anesthetized setup before. We hadn't built the awake animal setup before. So but this forced us to do this, an awake animal, for the first time, because all our mice and our non-human primates were actually anesthetized up until
It's just what's going on in my mind is that when you're sonicating during the task, then there's a potential for confounds. Whereas if you had a lasting effect that even was minutes, then, having done it beforehand would have, kind of gotten rid of that argument that, maybe it was a confound or whatever. So I'm just kind of trying to sort that out in my head.
Yeah. I think it wasn't as consistent across sessions and animals, because the animals, as have different responses to anesthesia, depending also, on the day and how many sessions of anesthesia they had before. So it wasn't as, because we couldn't get the same clear effect that I'm going to show you here.
Mm-hmm. Okay, thank you.
Sure. Yeah, so this is exactly what is happening from so I'm going to show you basically two things. One is how fast the animal is responding to the cue, which is called response time, and then also how many of those targets. So first you have the cue, and then you see the cloud of dots basically swirling. And if you have the right target that you pick to the right of that or to the left of the cue, then it's also the accuracy of that target. So how fast responding and how accurate is their motor response. And we can see that the response time, the response time is dropping during sonication, and it stabilizes after, a few minutes, if not hours. So we do get an immediate response time decrease. So they become they respond faster to the cue, and then the accuracy is also increased as a result of sonication. This is the blue curve here on the right versus no sonication. So slightly higher accuracy. Coherence here shows the ambiguity of these dots. So if they're very coherent, it's very clear that they're swirling to the right or the left. If it's under 0.5, it becomes more ambiguous, and so it also tests for attention here. But the accuracy was slightly higher, and the response time slightly lower. Whether you have high motivation in the large circles or low motivation. So we saw that the motivation with the 5 drops of juice in this case versus 1 drop of juice was actually also motivating more to get a lower response time. So just by opening the berry itself, seems that the animal has a different motor response aspect. All right. So
and you didn't have as a control the case of no microbubbles.
No.
With sonic. Okay. Yeah.
No, we didn't. Yeah.
Okay. Yeah. Thanks.
There is actually, that work is being done right now by Vince Ferrer's group, and but we're still trying to figure this out, whether we have opening or not. And he's doing modulation with both without opening and without bubbles, and compares the two. So very briefly, clinical translation. My group has been successfully translating this to humans with FDA approval, of course, over the past 5 years. And this is our setup. So outside the MR, we use MR that's already been acquired by the subject with fiducial markers. I'm going to show in a second. On the patient's face, so that we can able to register some of the facial features to the brain that are then detected outside the MRI by an infrared camera, and then we register the transducer where we want to target with respect to the MRI that was recorded. This is some of the work that Sue Abe in my lab has done to see how well we did compared to where we targeted. So the blue line is where we wanted to target it, and the green is where we actually open. So we're not exactly always along that along this trajectory for various reasons. One is because our neuronavigator is not as precise with orthofiducial markers. Also, because we have, as we know, angle incidence effects with the skull that we use, as I said, simulations to predict, but some of the aspects of the potential trabecular bone here may be deviating or being further. But overall,
just to be clear, your line here is using a simulation?
yes.
So, okay. And so that would take into angle effects and refraction and all of that. Okay. And so you're saying that the simulation actually wasn't that accurate.
Wasn't as accurate, and also our navigation. So we use a navigator to find that trajectory, but the navigator also has errors that we're actually evaluating. I don't want to blame everything on the simulation, but there's also the factor of navigating and finding that trajectory in those subjects. So this is actually very interesting because you can see on the MRI where you actually had the effect, right? The opening, something that in modulation, for example, it's not, we still don't have as much, like exactly where the focus landed. So this could shed some light about potentially, using the people who are using neuronavigation for something like this. Obviously that's used in TMS and ECT, and that's probably known even more how the navigator could be, introducing errors in their targets. I mean, this is a chronological, by the way, display. So we're doing better with our recent subjects than we started with. But we have ways to go about getting it every time.
Well, if you're doing better, then what are you improving?
So we are improving our stimulation. So we are using also the neuronavigation better with more fiducial markers than before, and registering. We found actually some errors that we were making from using the neuronavigation map to the simulation. So there was some bugs here and there that we sorted out, but the main thing I think is the attenuation aspect. So a lot of in the beginning here we didn't have the right attenuation that we ran with through K-wave.
Yeah. So one of my assessments, and tell me if you think you agree with this, is that when you do simulations, it gives you a reasonable confidence of where the focal spot might be, but not necessarily that we are very good at estimating what the pressure will be. Do you agree with that, or?
Yes, we had that problem in the beginning. We underestimated the pressure, and then we, for example, here we had a deeper region that opened than what we intended, and that's because we underestimated the pressure. So now we use the elastic simulation for the K-wave, so that has the insertion loss as a result of the attenuation, and we found that this is more accurate when you take into account the insertion loss on the simulation itself. Mm-hmm. So that's one of the aspects that you have to take into account. Okay, so then we basically proceeded after planning to our first patient here, patient 1 that I showed you in the previous slide. And then we opened through these fiducial markers, as you see here, these metallic beads that can be picked up by the infrared camera. And then the robotic arm here with the transducer is being registered with the MRI, as I mentioned. And then you can see that in green is a transducer. There's a hole in the middle because we use a cavitation detector right in the middle here that we can see in real time the cavitation change, and that allows us to see whether the bubbles were able to infuse the focal spot. And you can see the rapid rise here and the maintenance of the oscillation or cavitation of the microbubbles as a result of the ultrasound application. And this is our opening in that patient. It was in the order of 320 millimeters cubed. And then what I wanted to show here is that we also did PET to see whether we had any beta amyloid change. And we did have some amyloid change here as a result of the opening that we, I didn't have time to show you that we actually showed also in the mice, amyloid and tau reduction. And then we wanted to see whether that was had any cognitive memory improvement as a result. And we did this in all the 6 patients that we opened the barrier. The patient 3, we did not have successful administration of bubbles, so there was no blood-brain barrier opening. But there was ultrasound, so that you can take it as a ultrasound control in this case. And we could see that in half of the patients, we get momentarily decrease of the actual amyloid, but then in 2 of the 3, we had rapid increase after the second follow-up, which is between 3 weeks and 3 months after opening. And in only 1 patient, we had a sustained amyloid reduction. So that's it on the Alzheimer's front.